Thank you all for those of you who are joining promptly. We see people still entering the webinar. Meanwhile, we do have this QR code up on the screen. Uh, should what you hear inspire you so much, you'd like to support these wonderful faculty in what they're doing, but we'll give it another minute before we start the program. Okay, it looks like things have slowed down in terms of people joining the webinar, so I'd like to get us started. My name is Tom Harmon, Executive Director for Development here at Mount Sinai, and I have the wonderful privilege of working with the amazing faculty of not just the neurology department, but of the Bonnie and Tom Strauss Movement Disorder Center in particular. And we have many of those faculty here specifically to talk about what they heard at the recent International Congress for Parkinson's and Movement Disorders in terms of new research, new potential therapies, but then also to talk a little bit about some of the work going on right here at our Movement Disorder Center going into 2025 that they're most excited about. So without further ado, I want to turn it over to Susan Bressman, Director of our center. Thank you, Dr. Bressman.
And thank you. And I want to thank everyone for being on this webinar. It turns out this is our third webinar. I'm just welcoming you all to hear about our center. You're going to get to meet some of our team. You're going to learn about what's new in the field. We're going to be talking to you about research. We're going to be talking to you about sleep. We're going to be talking to you about clinical trials, and you'll hear a little bit about that. And you'll also hear about non-medical treatments. So we're going to try to cover a bunch of topics that we thought would be interesting, both in terms of sort of pragmatically, today, what can you do that might be helpful in your lifestyle, with your medications, with your sleep, but also where we're headed for the future. I think that's a real important part to keep in your head, to think about where we're headed and what's coming down the pike. So my role today is really to update you a little bit about this meeting we recently had. And it was the International Movement Disorder Society. It's actually was originally called the Movement Disorder Society. Now it's called the International Parkinson's and Movement Disorder Society. And unlike some other organizations, which are more national, more local, more regional, this is really a world organization. It's global. It gives us an opportunity to meet with colleagues from far-flung places all over the world. And we learn from each other. It's really a wonderful opportunity to see how other people practice, how they fund their research, how they take care of patients, and just to sort of socialize and get to know our movement disorder world. So it's really a wonderful opportunity for us. But the minus of this is that it is global. Dr. Shanker brought that to my attention, that our meetings are held in ridiculous places. I mean, Japan, we have one coming up in Seoul. We have a bunch in Europe. The next one's in Honolulu. So it's a long trip. It's expensive. But this year, we had our meeting about a month and a half ago. We met in Philadelphia, Philly. This was like the best possible place to hold a meeting. You just had to take the Amtrak train. We were happy campers. And it gave us this opportunity to meet with our fellows. I think we have a picture of us with the fellows. So, we've been graduating about 2 fellows a year for over 20 years. They're all over the United States. They're just a fabulous group, and many of them have gone on to really important positions, roles in academia. I mean, they run movement disorder programs, they run residencies and fellowships, they're doing important research. So it was really terrific to see them. So that was one real terrific plus of the meeting. The other plus of the meeting is that we participate. So some of our faculty taught courses, and I counted, we had 17, maybe more, scientific presentations. So we also present our research at these meetings, And we often have, as part of our research, our trainees, residents, and fellows actually help us enormously do this research. And it's a great joy for them to be at the meeting, to present their research. You know, it's kind of a little nerve-wracking. You stand by your poster, smart people come and ask you a lot of hard questions, and you hope you can answer them. Or sometimes if you're there at cocktail hour, nobody shows up and you feel nobody cares about your research. But it's really a wonderful opportunity actually for the trainees to learn about research and that community of other researchers and to feel connected to that. So the other piece of the meeting, and I'm just going to introduce this, the other speakers will speak to this more, so you'll hear more about it, was to hear what's going on in the field, what's new, and what people are doing, what kind of research, and what are the hot topics. So for me, the interesting part, which I think was presented in different ways during different sessions, is how heterogeneous Parkinson's is. You know, we always used to say you meet a person with Parkinson's, you met one person with Parkinson's. Everybody's different. And I think clinicians have known this forever. We know that you can be 38-year-old woman having leg tremor and we're diagnosing Parkinson's, or you can be a 75-year-old person who has a change in their gait, or blood pressure changes. And, you know, they're really different clinically. How we go about diagnosing, the conversations we have, the treatments, how we approach treatment are really different. But I think scientifically, we heard a lot about that too. And a lot of this has been sort of brought about by genetics. So, you know, over the last, it's really only, 20 odd years, since maybe 25 years since the first gene for Parkinson's was discovered. And since then, there's just been this ballooning in understanding the genetics. About 15% of people globally will have an currently identifiable gene for Parkinson's. So it's not uncommon. And, the pathologies in the course share features, but also differ. And pathologically, they differ. So one hot topic is, and I think some of you may have seen the blast from the Michael J. Fox Foundation, multiple times about this new biomarker or old biomarker that we now know we can actually measure, alpha-synuclein. So what's alpha-synuclein? It's a protein that misfolds and sort of clumps up in the brain and has been known actually for years, although they didn't know it was alpha-synuclein, used to call them Lewy bodies because Lewy was the pathologist who identified them. So now we can actually measure this protein in spinal fluid reliably, also skin biopsies, and they're looking to be able to measure it in blood as well. So now that's become sort of the way we classify Parkinson's. If you have alpha-synuclein that we can measure, then you have a synucleinopathy, you have Parkinson's, even if you don't actually have all the features, like all the motor features, you've lost your smell, you have REM behavior disorders, you have abnormal sleep pattern, you have a family member with Parkinson's, and we find this alpha-synuclein, you might be in one of these early clinical trials, right? So, and that's sort of like, that's the new holy grail. That's the defining feature. And there was a debate actually about whether this classification and, you have clinical features, you don't have clinical features, makes sense. But the part to me that was interesting was, first of all, alpha-synuclein isn't present in everybody who has Parkinson's disease. There are some forms of PD that don't develop these Lewy bodies. So what do we say? That person doesn't have Parkinson's disease. They have tremor. They have walking problems. They don't have enough dopamine. We know that. They get better with Sinemet, with levodopa, and they don't have Parkinson's. Why? Because they don't have synuclein. So, this is a debate over how we classify the nomenclature. Also, synuclein, the way we now measure, doesn't track progression. So it's a biomarker for diagnosis, but not for actually progression. But one really sort of fascinating presentation by this guy, Jeff Cordover, was that if you go back to maybe the earliest people with PD, it may not be synuclein. It may be something called tau, another protein that may be the first abnormal protein that sort of misfolds or collects in the brain. And it sort of reminded me of the conversations we've had over the last 25 years about Alzheimer's. Is it tau or is it amyloid? Like, what's the chicken? What's the egg? What happened here? And I love the fact that even though now it is like dogma, we use synuclein, we use the seeding, this guy went up there and said, well, maybe that's not the earliest thing. Maybe there's more to this story. Maybe that's simplistic. So I love the fact that neurologists, it's sort of like, well, maybe the emperor's not wearing clothes. So I love that we go back to basics and we ask questions. It's not that I don't think synuclein is important. It's very important. And I think it helps for clinical trials because you don't want a lot of heterogeneity in clinical trials. So why is it important? Well, if you have a drug that only targets synuclein and you're a PD patient that doesn't have synuclein, maybe that's the wrong drug for you. Or maybe you have, let's say, Parkinson, maybe you have a different kind of mutation, and it's really energy metabolism that's the problem. It's not synuclein, may not even be tau. It's more like these little energy manufacturing machines inside your cells. So maybe we need to boost that part. So I think when we get into this whole idea of personalized medicine, of precision medicine, how we target our treatment to the patient, it's everything about the person, and very importantly, what is the process in the brain that we need to target. It's sort of like cancer, same idea. So I thought that was, to me, that's the exciting part, that people are now really, looking at different mechanisms and working on therapeutics that are more targeted. And now
Awesome, Dr. Bressman, thank you so much for that overview. And
I'll
again,
shut up.
if people have questions, you're welcome to put them in the Q&A function, and we received some questions early on. We'll try to answer some of those. But Dr. Bressman, maybe you could now introduce Dr. During.
Oh, yes. So, yes, I want to introduce Dr. During. He's relatively new member of our group. Wait a minute, Emanuel, how long ago?
In just 2 years.
2 years.
2 years, yeah.
And he is providing like a whole new level of care for our patients, which is just, and also research. So, as many of you know, people with Parkinson's have all kinds of sleep problems. It's a giant piece of taking care of people with PD. And Dr. During's focus, his research, his practice, his clinical care is really focused on sleep in people with PD. You're an associate professor, and he has got incredibly interesting research that he's doing. And now I'll keep quiet so he can talk.
Thank you so much, Dr. Bressman. Yeah, I was listening carefully to your introduction, and I'll have a couple comments actually relevant to this intro. So yes, I take care of sleep issues in Parkinson's because they're just very common. Yeah, almost never see a patient with Parkinson's who doesn't have sleep problems. I mean, sleep problems are common as well. So, but they affect people with Parkinson's more than anyone else for several reasons. First, the disease itself, the synuclein or the pathology tends to affect these areas, very small areas packed low down in the brain, in the whole brain, the brainstem, we call it. And those areas are those areas that control how we feel during the day, how we sleep at night. So the wake sleep system, the day and night 24-hour central clock. These areas that really control how we feel and how we sleep are affected very, very early in Parkinson's. But there are other factors, because that's something we cannot change. But there are a lot of things we can change. I always tell my patients, make sure your symptoms are, you're comfortable at night. You can turn in your bed. You don't have cramps. You can move easily, because that's something maybe we can help you with further. That's one. But and then there are simple things such as For example, as the disease progresses, or maybe you have less motivation, you start moving less, you do less, your sort of activity level reduces. Some of it is related to Parkinson's, but a lot is not. And so, like I, tell any patient, when people don't sleep well and start having low levels of energy during the day and want to nap a little bit, they feel a bit sleepy during the day. It's a vicious cycle where when you let yourself go, actually what you do is you send to your brain the wrong signal that daytime is actually a time where you could stay inside and maybe rest. And nighttime then, as a result, is also maybe a time where it's okay to be up. Well, that's obviously the wrong signal. So there's a lot about the behavior and what you do and what you can do every day that really is going to make a huge impact. For example, every time we go outside during outdoor, where during sunlight, during daytime, when there's light outside, actually in the back of the retina, there are receptors that capture the light and send a strong signal to the brain to wake up. And also at night, this strong signal of light during the day is going to have a very beneficial effect on your sleep. As you walk, you feel less, you cannot feel sleepy and walk. It's just hardwired. We can't. There's a survival reason is you can't just, fall asleep as you stand up. This is very dangerous. So you can't be sleepy and walk. So it's a great way to fight sleepiness is actually go outside and walk. Plus, is good for Parkinson's, but not just for Parkinson's, good for cognitive functions, good for mood, it's good for anxiety. So it's good for everything. So we really start with this sort of solid foundation. And then on that, we can, sometimes consider other things, but really starting with that, most 80% of my patients will start feeling better during the day, sleep a bit better at night. I could say a lot more about this, but I think, another common problem that is extremely interesting from I would say a diagnostic point of view is, as you know, with Parkinson's, a lot of people start acting out their dreams. They start moving in their sleep, talking, screaming, depending on the dream. It doesn't affect everybody with Parkinson's, but a subtype, or maybe about half people with Parkinson's. And the reason is simple. Again, the pathology, the synuclein deposits in areas that are supposed to control our muscles. When we dream, we're not supposed to move. So this area in the brain keeps us paralyzed. So every about 90 minutes after we fall asleep, we go through a cycle of 10, 20 minutes of what we call rapid eye movement sleep, or REM sleep. And this REM sleep is the sleep during the stage of sleep when we dream. We may not remember our dreams, but the vivid, complex dreams that we may remember, they happen during REM sleep. And during REM sleep, at the same time, the brain is very active. The muscles are not. They should not be active. So that system, there's a lock system in the brain. So that system fails in a lot of people with Parkinson's for the reason I mentioned. So even more interesting, it tends to, for about 1/3 of people with Parkinson's, starts before, I would say, the diagnosis of Parkinson's, many years, sometimes 10, 15 years. And then nobody knows what's going on. They receive it, and eventually they may, develop Parkinson's disease. So it's an early symptom for many people. It's a common condition, REM. It's called REM behavior disorder. So it's treatable. That's the good news. So the best treatment, I would always recommend my patients start with melatonin, but there's one way to do it with melatonin. And in general, melatonin should be taken every day at the same time, same clock time. So it's not before bedtime, because that can vary, but really putting an alarm clock and pick a time and stick to it, plus minus 15 minutes, I would say. The more consistent you are, the more benefit you'll get. Again, because that controls in the brain the central clock, this clock that keeps track of time, 24-hour cycles, etc. The way to do it is, that's the only way to do it. If you do that overnight, weeks and months, the effect builds up, and typically it will reduce the RBD symptoms. In the long run, that's the second benefit. It seems to be neuroprotective. So there's emerging data from Germany that is so impressive. It's really hard to ignore that it may be neuroprotective and protect the brain from further progression. It may prevent Parkinson. So there's a lot of work around melatonin. There are other treatments.
Actually, Dr. During, we'll pause you
Sorry.
there for a second. I want to make sure we get everybody in with what they wanted to share from both the meeting and in their work. But thank you for that. I'm sure we'll get, I know we've already gotten some questions around sleep related items, so we'll get back to you shortly. But I'd love to turn it over now to Dr. Joohi Jimenez-Shahed to talk about cell and gene therapies.
Great. So thank you, Tom. So I'm Joohi Jimenez-Shahed. I am working over at the West Side. And as some of you may know, my main clinical and research interests are in deep brain stimulation, so surgical therapies for Parkinson's disease. And I wanted to take a moment to kind of share with you some of the new developments that are going on in the field. Some of these were reported earlier than at our recent meeting, but there were certainly a lot of conversation about them at that meeting and a lot of information gathering that all of us were doing, trying to understand what's going on in the field and how far we have progressed. When I started practicing about 20 years ago, we were just starting to learn about cell therapies and gene therapies, and there was still these unanswered questions about, what the effects were and how safe was it and who were the right patients to get these treatments. And I think what we've seen over these last couple of decades is quite a bit of an advancement to the point that we are really at I think a turning point. And I think there's some really good, solid clinical trials in this area that are now going on. And that's what I kind of wanted to share with you today. So I think in order to do that, probably good to just start with a just brief description and explanation of what gene and cell-based therapies are. So let's start with gene therapies. Gene therapies are techniques that modify a person's genes to treat or cure disease. And you can do it in different ways. You could either take a disease that is caused by a gene and maybe replace that gene with a healthy one in order to improve disease manifestations and symptoms. You could maybe deliver a gene that you could inactivate a disease-causing gene that wasn't functioning properly, or maybe you could introduce a new or modified gene into the body to try to help manage the disease or help treat the disease. So in Parkinson's disease, if you think about that a little bit, there's probably a few different ways that we could use gene therapy. One could be, and I think people have thought about this for a while, is to see how we could increase dopamine production by delivering genes for enzymes that are important in the synthesis of dopamine or actually producing dopamine. Maybe we could deliver different growth factors or other proteins that are important for the survival of dopamine neurons so that we can slow the progression. Maybe there are other genes that we could either turn on or off to try to help that dopamine circuitry work better. And then certainly we know that there are forms of Parkinson's disease that are related to abnormal gene function, and maybe we could counteract some of those things like maybe GBA or LRRK2 type diseases by introducing other genes that can counteract the the effects of the GBA or LRRK2 mutations that cause Parkinson's disease. So doing this type of therapy requires a different kind of brain surgery than deep brain stimulation. So some of you are probably familiar with DBS. This is where you put wires into the deep brain structures. Those wires are connected to an extension wire, and the extension wire is connected to a battery, which functions quite like a pacemaker, looks very much like one. We're delivering the electrical signals into the brain instead of into the heart. But the idea is similar, and then we program the battery in order to deliver the effects, which is really to improve the symptoms of Parkinson's disease. With gene therapy, what we're actually having to do now, similar brain surgery in the sense that you have to get something into those deep brain structures, but what it is a gene product that's packaged into what we call a vector. So a vector is just a carrying case for the gene, and usually these are some sort of like a type of an inactivated virus. Okay, so viruses usually cause disease, but if you engineer them, if you inactivate them, then you can actually deliver them and use them to kind of get a new gene into the body. And that's exactly what they do, because they make a beeline for the nucleus, insert that genetic material, and then that genetic material now becomes a part of the host machinery and can actually function just like normal genes would function. And so this kind of allows us to think about new and different ways to treat Parkinson's disease. So some of the challenges that we've seen in the past with this are getting the treatment to the right part of the brain, making sure there's no immune reactions when we do that treatment, and also thinking about, which are the patients that might benefit most from these types of treatments. And I think Dr. Bressman explained, why we think of this condition as very heterogeneous. We've probably got a collection of Parkinson's diseases, and not all treatments will work for all patients. So what was really interesting to see come out in the last couple of years are some new results of a gene therapy. Some of you may be familiar with a molecule called GDNF, glial-derived neurotrophic factor. And this is a molecule that is important for the survival of dopamine neurons. And over the years, there have been a lot of different attempts at trying to deliver GDNF into the brain to try to help preserve those dopamine-containing neurons. And they've been challenging to execute with variable results, and kind of have had their fits and starts in terms of the previous clinical trials. But this company called AskBio, what they did was a little bit different. They found a way to deliver it using a viral vector, but they're studying different groups of patients. They're actually looking a little bit earlier in the disease course. So they had a couple of cohorts of patients in their first phase 1 study. They looked at mild patients and those who were a little bit more moderate. And they found that when they delivered this therapy, that it actually helped to improve some of the symptoms. And in some of the patients, actually, they were able to reduce their medications. And so I think this is going to be exciting to see how it plays out. It was a safe therapy, but now they're conducting their phase 2 trials. Cell therapies, on the other hand, are where we deliver cells into the brain. And I think the one that people kind of are most interested in is stem cells. And those are, I think people have a lot of hope about what stem cells can do, but ultimately I think these are, really challenging to kind of develop and to implement. And so we've seen that over the years in various attempts. But usually with the stem cell therapy, what we're talking about is induced pluripotent stem cells, not embryonic stem cells. They have to come from a donor, and the donor either is a patient or a healthy individual whose cells are kind of taken. You extract the relevant cells and you kind of induce them to become a stem cell, and then you can treat them a little bit more specifically to become a particular type of cell. So maybe it's a heart cell, maybe it's a liver cell, maybe it's a nerve cell. So that's the whole concept of induced pluripotent stem cells. And this kind of way, the other way you can do this is an autologous stem cell transplant, where a patient actually donates their own cells and we produce the same type of induced pluripotent stem cell in that same way. And so what's really exciting here is there's a company called Blue Rock Therapeutics, and they have developed a stem cell therapy that actually is able to produce dopamine. And what's really kind of cool about this is that rather than taking pills that you probably are familiar with, where you get these sort of really high concentrations of medication, that's kind of not the normal way that your brain deals with this neurotransmitter. And so we think that sort of delivery is really a big factor in why patients develop fluctuations and dyskinesias. But if we can get this dopamine producing stem cell into the brain, it can start producing the dopamine in a much more natural way and deliver it in a natural way. And in that regard, might be able to prevent the development of these dyskinesias and these fluctuations, and really kind of change the way that we approach treating Parkinson's disease. And again, this company, Blue Rock Therapeutics, has published their phase 1 study results, which showed, again, that the treatment was safe. They did a low dose and a high dose, and they found that in the high dose group of patients, they actually did have symptom improvement. There was reduction in their motor scores. They did not develop any worsening of their dyskinesias, and otherwise this was done, very safely. And so the thing that I wanted to just kind of share with everybody is that particular trial is going to move on to phase 3 studies, and Sinai is going to be a site for that, and I'll be the site investigator, and we will be looking to enroll patients into that clinical trial sometime next year. So we're going to be a part of some of these new advancements. It's really exciting to see kind of how far this field has come. So thank you.
Thank you, Dr. Jimenez-Shahed. And now we'll come back with some questions for folks, but I want to get Dr. Vicki Lynn Shanker into, she oversees our education program, so hopefully she'll speak a little bit to that, but also some of the more holistic approaches she heard at the conference. Dr. Shanker.
Yeah, I'm just going to apologize in advance that I'm truly in New York City because there's a construction zone happening here. And there's been times while we've been in this webinar where it's been so loud, I can almost not hear the webinar. So, I apologize in advance. I'm going to highlight two different talks that I heard at the MDS, which are not medication related, but I think are really important. And I'm going to actually first talk about exercise because it's just some new concepts that I thought would be interesting. One is the fact that although the course was called rehabilitation, they start to talk about a different concept, which is prehabilitation. And I've seen some research on this over the years, which I think is really important, which is really get to the exercise before we actually have the problem. And so thinking about creative ways that we can go into exercise and therapy that will actually stop the problems from happening. Some of that is by doing multitasking, teaching people to practice doing activities while they're walking. It just sets off a different area of your brain, this kind of executive function area. And again, by using different pathways, we may be able to prevent things from happening. And just to refer to an old Movement Disorder Society meeting in this concept, there was a really cool study with this physiatrist who worked with Dr. Nutt, another movement disorder specialist. And what she did was she actually pushed people to get to who did not complain of freezing of gait to freeze by making them do really tough things like running through doorways and things. And once she got that symptom to occur, she was able to teach them behaviors to have it not happen, to the point where she showed videos of people running through those same mazes and circles like in their homes and never freezing. So just that concept of being able to do physical therapy to learn techniques that will keep things from never happening, which I thought was cool. The other thing was kind of this combination therapy of sensory motor cognitive training, or SMC. And there's just thinking about rehab in different ways. So one is dual tasking, which I sort of just alluded to, which is basically progressively having people simultaneously do two tasks. And you can make them more complicated. You can get people to run and come up with a list of groceries or carry things. But doing these kind of therapies, which has been studied, has been shown to really help in terms of rehab. And I should mention that this combination, when I talk about what it's helping, these things are helping things that we don't have medications for or surgery interventions for: postural instability, falls, freezing of gait, and cognitive symptoms. And so that's what it is, so one is the dual tasking. The second is cueing therapy. So we've known about this for freezing of gait. And again, it's using external stimuli, whether that is lines on the ground or auditory sounds, to improve the movements. And they found that while we have focused on walking and freezing, they now know that people have freezing in their upper extremities, which we kind of see when we push you to do movements in the office, and that you can use these same kind of visual cueing in training and rehab to overcome some of those motor difficulties. And then finally, the third component is virtual reality. And that can come in two ways, both gamification stuff. So that's like kind of the games that your grandkids have that they can play with at home, but also these kind of immersive virtual reality experiences. So imagine a room where the video projection shows you in a forest, and you can actually take steps or duck or walk over a log to simulate real life. And a lot of research, and there was a lot of posters at the meeting on the virtual reality. So that combination of dual task therapy, of doing multiple things at once, cueing therapy, and virtual reality, is sort of like this next phase of exercise that I thought was really cool. And then the other lecture that I'm going to highlight was in the beginning Parkinson's courses. And that was, again, a non-medical talk, which was a holistic approach to Parkinson's disease. And I think some of the things that we actually practice, which makes me very honored to be part of this group, and it just reflects back on, how things are different elsewhere, but also pose to us, I think, some questions. So just to highlight some of the things that were discussed in this talk, which was one, just the basics and the importance of the time that we spend providing the diagnosis, and just the reality that many neurologists are given a very brief time with patients, and that the actual time to diagnosis, and the speaker was actually from Denmark or the Netherlands, and so was talking about how, like, you might have 10 minutes, say you have Parkinson's, here's some levodopa, see you, and patients not really understanding and what's happening, and just the lack of compassion that happens with this, and the importance of time, and then refer to some really good papers that have written about this, but also the importance of the time that we spend with patients, really understanding what patients are taking that are outside the things that we prescribe, right? So a lot of food things people are interested in, and he brought up turmeric and coffee, cannabis, and those sort of things. I know it's important for us as doctors to know what people are taking. Some things are completely fine, even if not fully vetted, and some things have real side effects that could interfere with things that we're prescribing. And talked about how, you know, as people will even spend ridiculous quantities of money on things that may not be helpful at all. And he even talked about this gut product that actually could cause worsening Parkinsonism that was sold to help people. So important for us to be able to provide information on things that don't have good evidence, that don't have good research, and could hurt our patients, or could just waste their money, to be honest. And so he referred to a really good book called Holding Still Together by the first author is Strap, like a strap, that really talks about the importance of doctor-patient relationship and working out care together. And actually another concept that was brought out in this talk that I think was really important was just the gender difference of how we take care of people, and talked about how, you know, a lot of the research was done with men, and we're maybe overdosing women early because we're prescribing them the same doses that we're giving to men. And also referred to a great free book that's called In Her Shoes. There's a fictional novel of that, but there is, I could put it into, or I can share it, but it's YOPD, Young Onset Parkinson's Disease, YOPDwomen.com, is really written by women who have young onset Parkinson's and their experiences of dealing with Parkinson's and pregnancy, their menstruation, medications, and those sort of things. And talked about, there's a paper that was written called The Unmet Needs of Women Living with Parkinson's, talking about how we need to do a better job of really considering the gender differences in the clinical care so I think those are from the while the drilling is continuing, the highlights of the two talks that I attended that I thought were very meaningful.
Well, thank you, Dr. Shanker. For what it's worth, I can't hear the drilling at all, so it's not distracting to us, although thank you for powering through. Dr. Bressman, we've had several people ask some general dystonia-related questions, and maybe you could take a couple minutes to address that. And I will also add that whatever questions we don't get to in this webinar, our intention is to follow up with the questioners after the webinar with any answers we can provide. But Dr. Bressman.
So as a movement disorder center, we take care of people who have all types of movement disorders, which pretty much is, you know, the topic keeps getting wider and wider. I mean, if you have walking problems, you know, if you've had a stroke and you're weak, I mean, that could be considered a movement disorder too. But one of the movement disorders that classically went under our umbrella is dystonia. And dystonia is really just these involuntary, usually kind of twisting movements that can occur in childhood, can occur later in life. Examples sort of, or they're not always twisting, they're contractions like blepharospasm, where your eyes involuntarily close, or torticollis, where your neck is pulling off in one direction or another. It can cause writer's cramp. In kids, we often see it affecting the legs, so the gait is affected. And you know, our center's actually been very active in researching and treating people with dystonia, and surgery, deep brain stimulation, can be sort of life altering for many people with dystonia. So we didn't talk about dystonia per se today, but there is a relationship between Parkinson's and dystonia. Sometimes I answered this sometimes Parkinson's can actually begin with dystonia. And there are some genetic forms of Parkinson's where it's not that uncommon either. Especially if we were talking about young onset Parkinson's. So not uncommonly that can begin with dystonia. But usually, as I answered in the Q&A, there are other clues that it's not just Parkinson's, that there's some, that it's not just dystonia, that there's something else going on that leads us to the diagnosis of Parkinson's. There was also a question about the pathology. So interestingly, in many people with dystonia, it's really hard to see what we would call degenerative changes in the brain. There are very subtle abnormalities that some people can pick up when they, do really subanatomic pathology. But for the most part, people with dystonia just have dystonia. There's not any degenerative thing going on in the brain, and synuclein doesn't accumulate. But DBS, like we said, some Parkinson's can begin with dystonia. That circuit is involved. The Parkinson's circuit of movement is involved, and DBS can help dystonia people and Parkinson's. So it overlaps actually in a lot of different ways, but they're different.
Great. Thank you, Dr. Bressman. I want to kick it back over to Dr. During. We had a few people ask follow-up questions around the use of melatonin, even as it relates to dystonia. Also, some folks asked about REM disorder and Parkinson's. Also, just broad questions about early symptoms. Maybe you could address some of those and then even tie that into your own research, which I know you're doing in early diagnostics and screenings with wearables.
Right. Thank you. So melatonin, again, I'd like to emphasize, we typically don't use melatonin for sleep per se as a sleeping pill. In Parkinson's, that's the wrong use of melatonin. We use small amount, and I always recommend 2 milligrams at the same clock time. Has to be at night, before bedtime. And that's how it really regulates sleep. See it as a regulator. And over time may have a neuroprotective effect. It's not a sleeping pill again. So that's the way to do it. About early symptoms of Parkinson's, I mentioned REM behavior disorder is a classic. So it's interesting, the population, really the patients I see often in my sleep clinic, because I also have a sleep clinic, are people who act out their dreams. And obviously they also have generally other symptoms of Parkinson's, early symptoms of Parkinson's. They have constipation, loss of smell, some sort of vague cognitive complaints. So I see them really over the years, and a lot of them develop Parkinson's. Others will develop dementia, more type of picture, but very similar, with this very similar early sort of phase. So very homogeneous, actually, group of people that I see with this early REM behavior disorder. So obviously, if we could diagnose REM behavior disorder early in a simple way, we could really then test treatments, test therapies in this early stage. And that's the whole point, because then therapies would be more effective, obviously. And then we could test many therapies and see which ones are best at preventing Parkinson's. Well, that's the holy grail. And the bottleneck, the main problem, it's a huge problem, is we're not good at diagnosing REM behavior disorder. It's very common. 1 million people in the US have REM behavior disorder. Maybe 1% of them is diagnosed. So we don't have a good way. So I started doing research on that a couple of years ago, and we found that people with REM behavior disorder, they twitch in their sleep. So these little twitches are very easy to detect for wearable devices. This is one of them. It doesn't matter. They Fitbit, Apple Watch, all these devices do the same thing. They measure this twitching. And then if you create algorithms to recognize these patterns of twitching that are characteristic of REM behavior disorder, then you can diagnose it. And that's exactly what we did. And that's exactly the research we're doing at Mount Sinai. So we're developing a new diagnostic tool, and it's incredibly effective, meaning we have about 90-95% accuracy in diagnosing REM behavior disorder. So now imagine all these people wearing an Apple Watch or Fitbit or an Oura ring. That means, well, we could diagnose Parkinson's so early that we could test therapies early on to have a greater impact. So this is what we're doing here.
Hey, thank you, Dr. During. Dr. Jimenez-Shahed, going back to you, maybe, I don't know if you want to take a combination of, I know you presented about some of the cell and gene therapy work you heard about at the conference. Your own research delves primarily into deep brain stimulation. We did have one question around freezing as it relates to deep brain stimulation, especially like about a year out after the procedure. And then there was also a question about CRISPR technology, presumably as it relates to things like gene therapy. Maybe you could address some combination of those things.
Yeah. So I'll take the gate freezing question first. So deep brain stimulation, we generally talk about it being effective for those symptoms that respond to levodopa prior to surgery. So patients with Parkinson's can certainly have gate freezing at any time during the disease. And if before surgery they're taking levodopa and the freezing tends to be better, then after DBS, it should also be better. Having said that, that's not always the case because freezing of gait is quite a complicated phenomenon, and it's probably not just purely related to having good amounts of dopamine or not good amounts of dopamine. We know that there's a lot of mechanisms that relate to the locomotor center in the brain and also going down into the spinal cord, and these are not necessarily dependent on or fully dependent on dopamine functioning. So for a lot of patients, they may either find that they don't get adequate relief of that particular symptom with deep brain stimulation surgery, or there could be a couple of other things that happen afterwards. One is that DBS doesn't cure Parkinson's, and so we know that as Parkinson's progresses, even after deep brain stimulation, gait freezing can continue to evolve, and if somebody didn't have it before, it could certainly show up, and it's just part of the Parkinson's disease. The other thing that can happen is that deep brain stimulation itself, it's a great therapy, but we have to have a very sort of strong index of suspicion about stimulation-induced side effects. And one of the stimulation-induced side effects that can happen is a worsening of gait, including gait freezing. And another one that's actually pretty common is speech issues and speech changes. So whenever I sort of hear about a person who has started to develop new gait freezing after DBS, the first thing that I want to do is to make sure that we're not creating part of the problem by the way that we're stimulating. And then secondly, once we've sort of satisfied ourselves about that, then we have to pursue other treatments beyond just stimulation or medication. So hopefully that answers the question about gait freezing. As far as CRISPR is concerned, I'll have to say that that's not an area that I know too terribly much about or that I know is very prevalent in the Parkinson's field, to be honest. CRISPR is a gene editing technique, so it's a little bit different from gene therapy. So what you're doing is really trying to modify the gene and to kind of make it function in a different way. And I'm sorry, I think I just don't have enough experience there. I don't know, Susan, if you're familiar with anything in this area in Parkinson's or in movement disorders, but I have not heard too much.
No, me neither. Not especially not in PD, but I'm sure somebody will figure out how to use that technology in some positive way.
Maybe we can go back to Dr. Shanker. We had a few questions related to different interventions for slowing PD progression. Maybe these can even be related to some of those holistic approaches you referenced.
Sure. Yeah. So, well, one is exercise, exercise, exercise. And there's still like Sparks trial and lots of studies that have been going on to show this. But whether you look at mice or whether you look at longitudinal research like the training heartbeat, all of these kind of data show that people with a higher aerobic activity seem to have slower Parkinson's. They look at people from Parkinson's sites from around the world. Those patients who are doing specific aerobic activity, 2.5 hours of aerobic activity or more a week, seem to have a slowing of progression of their disease. So, in terms of non-medication, I can think of a medication Parkinson's if you want to have a couple slides about exercise. Basically, isn't just how you think. See, I didn't delay my I'm sorry, it's not really just about rehabbing, but it's about potentially slowing progression. And they have lab research to explain how growth factors get released and they prevent cells from dying. So there's real science behind this. This is not just trying to make people work out more. And then there's things going on like in Europe and Brussels. There was a recent paper that came out this year that suggested the same mechanism that is in Ozempic may be helpful to slow progression of Parkinson's. There are terazosin, some of these other medications are in research from Michael J. Fox and other places. So there's things that are in study that have like signals and good research to back it to show that they may slow progression. We're not there yet to say, oh, definitely this is it. Probably exercise is more research than anything else. But I would say in terms of slowing progression, it's very exciting because there are a lot of things on the horizon, and maybe even as we talk about catching protein, like all the things everyone else has been talking about, getting people before they have their motor symptoms, getting them in interventions then, maybe getting them alpha-synuclein interventions that will stop the proteins from forming when we can catch them before they ever have their first physical symptom, but maybe just a sleep issue. That's going to also, I think, significantly slow progression of disease. So there's a lot of things that we're on the cusp of, and a lot of things that I think in the next year or two we'll know will really do in terms of pills may slow progression. So we're getting there, but for now, exercise would be the main thing I would say.
I'm sure nobody wants to hear that, but the science is the science, right? Did any of our other faculty want to weigh in on things that you're particularly excited about in terms of at least slowing progression?
So I just want to mention some trials that we have that are related to the genetics of PD, which are very exciting as well. So there's this one gene that predisposes to Parkinson's called LRRK2. And we think that protein's overactive. And there are all these drugs being developed to lower that activity. And we think that doesn't just apply to people with LRRK2, which is a small percentage, maybe it depends where you come from, but not the majority of people, but may actually work for everybody. So that's very exciting. Then there's another gene called GBA, and drugs being developed to maybe somehow alter that mutations effect. It may be because the enzyme it produces is just not enough of it around, or it may be related to the protein itself getting sort of stuck in the wrong place. So lots of research, including genetic research, gene research, gene replacement therapy for GBA. So that's very exciting. And again, people think that GBA actually reflects a very common mechanism underlying Parkinson's in terms of protein recycling, and that we need to sort of goose up that system. So yes, the genetics directly and sort of indirectly is informing a lot of research happening, including stuff we're doing.
Perfect. Thank you, Dr. Bressman. Dr. Jimenez-Shahed, back to you. There was a question around certain other, I guess, symptoms that could DBS be useful for?
So in Parkinson's, or the question about the other dystonia conditions?
The other dystonia conditions.
Okay. All right. Yeah, I just want to make sure I was answering the right question. So I think the question was about other forms of dystonia, and I think the comment there is correct, where we hear more about DBS in generalized dystonia or in cervical dystonia. Probably the other one in adult populations that might be more commonly discussed is maybe patients who have something like tardive dyskinesia or tardive dystonia related to medications that they've taken. There are other types of dystonia. We've certainly treated secondary dystonias. So those are patients who get dystonia as a result of a brain injury or as a result of stroke. And while the response isn't as great as in some of these genetic or just pure dystonia conditions, patients can sometimes get better results with the deep brain stimulation than they would with other traditional treatments like botulinum toxin injections or medications, muscle relaxers, et cetera. Then specifically about blepharospasm or MIGE. So MIGE syndrome is also known as craniocervical dystonia. So that's where the dystonia affects the facial muscles and the neck muscles. And blepharospasm is where the dystonia is restricted to the eyelids. And I think, for blepharospasm only, I think botulinum toxin injections are so effective, and other sort of local surgical therapies tend to be effective for that one. So we probably would not go to deep brain stimulation specifically for just isolated blepharospasm. The craniocervical dystonias, on the other hand, they are incredibly difficult to treat with botulinum toxin and with medications. And so we will see some of those patients coming to DBS or recommend it for them. I think the commenter, the person asking the question is right. I mean, it's a pretty uncommon condition. So that might be why we don't hear about as many patients coming to DBS for that. But I think there's evidence for it, and there certainly are some patients who can do well and experience greater benefit with the DBS for that.
Great. Well, for our final question, I'm going to ask one myself, which I'd like to sort of go around the horn. And obviously, these areas are very exciting, but oftentimes very resource restrictive. And I know all of you have very different hats within the center, different, whether as a clinician, as an educator, as a researcher, so many of you all three. So I want to ask the question, where would additional resources, in this case, say philanthropy, particularly make a big difference in your world, like what you're most excited about and where you see a major resource bottleneck? I'll go back to Dr. Jimenez-Shahed, then we'll go Dr. Shanker, Dr. During, and then close out with Dr. Bressman. So Dr. Jimenez-Shahed.
Yeah, I would say, for me and for the conditions that I treat and the treatments that I use, funding and support for research is absolutely essential. I think we have a treasure trove of data that we are collecting, and that really just sort of requires manpower to be able to look through it and to really learn the most that we possibly can to improve existing therapies and find new approaches. So that's what I would answer.
Dr. Shanker?
Just apologizing. We think I'm glitching because of the loud drilling.
Yeah, we hear you loud and clear right now.
Okay. Well, one is that I would say on twofold is that one goes back to research as Dr. Jimenez-Shahed said, like with our residents, and we, as Dr. Bressman mentioned, we had a resident who presented really interesting research that we were going to put for publication at the MDS that had a ton of people around her poster, because what she found was that when patients were on their initial levodopa trial, if they had cognitive symptoms, then they were more likely not to have Parkinson's and to have atypical conditions. And it's like a red flag for diagnosis. But what we need is like statistical support. Like it costs a lot of money to be able to have the person who can do the analysis for us. And that's something that's really hard when you're in training, when we don't have those kind of finances. So that's something that's really important. The other thing that I would just have to highlight is really our fellows. And it goes back to what I talked about in terms of holistic care, is that we give our patients 60 minutes in a room. I don't know many people, even movement specialists, who can do that. 20 minutes, sometimes 30 minutes. When we're with our fellows, they get a total of 60 minutes of doctor time. And that's time that we can give multidisciplinary care and actually teach the next generation of people to take care of movement disorders. And like if we didn't have that support, we number one, we need to make more movement doctors, because there's only an increasing number of the population that has movement disorders, and we're in high demand. But we actually, to be good doctors, we need to have the time in the office with those patients. And that when we get the financial support, we can tell Mount Sinai, no, we're not going to see a Parkinson's patient every 15 minutes. We're not dermatologists, and that they have a lot of issues. So to me, I think those are the two things: is the fellow support and funding that gives us the time, and the research support.
Well, beautifully said. I feel bad for Dr. During and Dr. Bressman to have to follow that up. But Dr. During, where would flexible resources really help you in your work?
Yes, I think we're reaching a point where we published on the accuracy of algorithm to detect REM behavior disorder. We have yet to test it in the real world, the general population, and this is the point where we would need some support to implement, to do a at-scale screening in the New York City area, and actually have people use a wearable, and then those who screen positive, invite them to the clinic to continue the study. This is where we would need most support.
Well, excellent. And Dr. Bressman, any final thoughts before I close this out?
I agree. Well, everything these guys said is correct. We need support for research, whether it's statistical support or research time for our faculty, because it's really hard to sort of protect that time. We talked about time protection, to do the work and to work with our fellows and to work with our residents and to pursue our research goals. For sure, we have to have our fellows are only supported by foundation and philanthropy. That's how we support them. And then the other thing that we didn't talk about is we actually need some support for our patients. Okay, so we have support groups, we have educational symposia, we have a social worker. No one will pay for our social worker. We have to raise the money for the social worker. It's so critical to our group. So it's also related to support so that our patients get the holistic care they need.
Well said. Well, thank you, everybody. Thank you to our panelists. Thank you for the great questions. Again, we'll be sending out an email, a follow-up with some additional resources. And frankly, as you consider your own year-end giving, consider how you might support these wonderful faculty and, of course, the whole team that is behind them that couldn't all be on the webinar today. But thank you all so much and have a wonderful end of 2024. Thank you.